Pandemics are not new and have increased by nearly 4 times over the past century. So what's leading to the emergence of pandemics? And are we creating a fertile ground for outbreaks to turn into pandemics? The answer could lie in cross-species transmission as a result of changing resource landscapes, deforestation, pouring into forest land, greater population density, globalization, greater animal-human contact in wet markets, climate change and connectivity, leading the virus to spread from one part of the world to another. These factors may have triggered outbreaks, and international travel may have facilitated the escalation of these outbreaks into pandemics. One such pandemic was swine flu. It surfaced in 2009 and has since seen several outbreaks.
2009 to 2010, swine flu, deaths 1,51,700 to 5,75,400, cause influenza A H1N1 virus. The 2009 swine flu pandemic was caused by a new strain of H1N1 that originated in Mexico in the spring of 2009, before spreading to the rest of the world. This virus was originally referred to as swine flu because laboratory testing showed its gene segments were similar to influenza viruses that were most recently identified in and known to circulate among pigs. This virus is believed to have resulted from reassortment, a process through which 2 or more influenza viruses can swap genetic information by infecting a single human or animal host. In 1 year, the virus infected as many as 1.4 billion people across the globe and killed about 11 to 21% of the global population. On 11th June 2009, the World Health Organization declared that the world is at the start of a pandemic. In India, the first case of influenza A H1N1 was reported on the 16th of May 2009 from Hyderabad, when a 23-year-old Indian carried the virus from New York to the southern India city. Swine flu's symptoms were fever, cough, sore throat, runny or stuffy nose, body aches, headache, chills and fatigue. Some people exhibited symptoms of vomiting and diarrhea. Most of those infected by swine flu were children and young adults, with older people immune to it already.
Even though it was well known that the influenza or swine flu or H1N1 primarily affected some sections of the society, like women who are pregnant, children, people who had comorbidities like diabetes, hypertension, obesity, these people were more affected and the mortality or deaths have occurred more in that section of the society. And I feel these people were vulnerable that time. Even today, if you look at the COVID-19, we find some sections of our society are more prone to acquire infection and also get complicated or land into complications and sometimes results into the death.
The pandemic began to taper off in November 2009, and by May 2010, the number of cases were in steep decline. On 10th August 2010, WHO announced the end of the H1N1 pandemic.
I feel that was an indication that such pandemics which had occurred in past are not going to be an exceptional situation, but likely to come in future too. And then somehow comparatively world managed it not so effectively, but with the number of people, number of cases, number of deaths, that was somehow managed by the world. But even after 4 or 5 years, the cases were occurring in different parts of the world, including our own country. Even though the pandemic was over, the influenza became a kind of a seasonal influenza, and now H1N1 is one of those strains which are not called as a swine flu, but influenza or the seasonal influenza.
In April 2020, the WHO drew a comparison between swine flu and COVID-19 to underscore the severity of COVID-19.
We know that COVID-19 spreads fast, and we know that it's deadly, 10 times deadlier than the 2009 flu pandemic.
Chinese researchers discovered a new type of swine flu that can infect humans and has the potential to cause a future pandemic. Though scientists have cautioned that the virus does not pose an immediate global health threat.
This newer variety of swine flu or H1N1 has been there in China in more than last couple of years, and thus it is known to the public health agencies and authorities, and I am pretty certain that the measures are being planned. So we need not get unduly worried, but the fact remains that such epidemics or pandemic, we should ensure that it doesn't become pandemic and it doesn't affect the total globe, or it doesn't even affect the countries. That need that really reflects the real need of developing public health systems.
The disease, which researchers called the G4 virus, genetically descended from the H1N1 swine flu that caused a pandemic in 2009. Chinese researchers discovered the G4 virus during a big surveillance program. From 2011 to 2018, they collected more than 30,000 nasal swab samples from pigs in slaughterhouses and veterinary teaching hospitals across 10 Chinese provinces. From these samples, researchers identified 179 swine influenza viruses, including the G4 virus. After 2009, the H1N1 virus in humans spread back into pigs around the world, and the genes mixed into new combinations, creating new viruses like G4.
We need to establish a system of appropriate surveillance, detecting earliest at the earliest clusters, ensuring that preventive measures are put into place much before the epidemic starts spreading, ensuring that the primary preventive measures such as developing vaccines and safe drugs, or the drugs which can cure such viral diseases or bacterial diseases, need to be concurrently evolved so that less and less number of people are affected. We cannot totally stop human-animal interaction, but we can definitely prevent human-animal transmission of diseases. If the disease that occurs in an animal cycle, if it remains in that particular cycle and doesn't jump the species, then the chances of such pandemics resulting into disasters of the present nature can be definitely achieved.
The pandemic that followed swine flu was novel coronavirus. Coronaviruses are a large family of viruses that usually cause mild to moderate upper respiratory tract illnesses like common cold. Coronaviruses are adorned by spikes on their surface, giving them a crown-like appearance. And corona is a Latin word that means crown. That explains the nomenclature of coronavirus. 3 new coronaviruses have emerged from animal reservoirs over the past 2 decades to cause serious widespread illness and death. SARS was the first among the 3. COVID-19 marks the return of a very old and familiar enemy. While the SARS virus killed about 10% of all infected individuals, the MERS outbreak, identified in 2012, had a fatality rate of around 35%.
2019 to date, COVID-19 caused SARS-CoV-2 virus. The COVID-19 outbreak was caused by a mutated coronavirus, SARS-CoV-2. As per official communication by Chinese authorities, the central Chinese city of Wuhan was ground zero for the novel coronavirus. China claims the virus emerged in December 2019. The virus spread like wildfire beyond China and took a heavy global toll within months. Comparisons are often drawn between COVID-19, SARS and MERS. SARS, or Severe Acute Respiratory Syndrome, was the first emerging epidemic of the 21st century. First cases of SARS emerged in mid-November 2002 in Guangdong province of China. It was first identified in Vietnam on 28 February 2002 when Dr. Carlo Urbani, an epidemiologist from the WHO office in Hanoi, examined a patient with a severe form of pneumonia with no known cause.
This particular infection is assumed to have come from animals such as either civet or bats of a different kind. The typical feature of this infection is when this infection took toll of almost 3,500 odd Chinese people, not many outside knew that this particular infection is occurring in China. But it was just that there was a businessman, US businessman, who was traveling to China and he was traveling back to US. So he was in a flight back, and then he developed suddenly this infection which causes pneumonitis like symptoms also in the flight itself. The result was people were worried, so they went to Hanoi instead of their intended place. And in Hanoi, interestingly, there was an Italian doctor who was visiting the hospital and who saw this particular patient, and he realized that this is a different kind of illness, and therefore he reported to WHO that I think this is a different infection itself.
At the end of the epidemic in June 2003, SARS-CoV had infected 8,422 people. There was no second wave of SARS. SARS was spread by close person-to-person contact, most readily by respiratory droplets. Symptoms of the disease included high fever, headache, an overall feeling of discomfort, body aches, sometimes diarrhea, a dry cough after 2 to 7 days, and pneumonia. Severe cases often evolved rapidly to respiratory distress and required intensive care.
SARS had a case fatality rate of 11%, which essentially means if there are 100 people who acquired SARS infection, 11 of them used to succumb to this infection. This was a droplet infection, and when it is a droplet infection, you had the preventive measures of using mask, safe distancing, and then washing your hands before you touch your nose and face. Coughing and sneezing or cough etiquettes have to be followed, and they were expected to be followed. The result, SARS came in very small numbers to India. There were only 3 patients who were seen at that time of SARS in India, and the infection died down by itself. But perhaps it died down mainly because we adopted stringent measures at that particular time, which are the measures which we are already prescribing even for COVID-19.
Another mutation of coronavirus resulted in MERS, Middle East Respiratory Syndrome, a viral respiratory disease first identified in Saudi Arabia in 2012.
This occurred in Gulf countries when they came in contact with camels, because camel is considered as one of those reservoirs from where this virus has also jumped. Both the viruses, the SARS virus as well as MERS virus, belong to the family of coronaviruses. They are called as MERS-CoV and SARS virus, which is also a coronavirus.
Humans were infected through direct or indirect contact with infected dromedary camels. While some cases were asymptomatic, typical MERS symptoms were fever, cough, and shortness of breath. Pneumonia was common but not always present. Gastrointestinal symptoms including diarrhea were reported too. Like in the case of COVID-19, the virus caused more severe disease in older people, those with weakened immune systems, and those with chronic diseases.
MERS had a very high fatality rate, close to about, if there are 100 people with MERS, 35 of them, they would die due to this infection. But interestingly, this infection was slightly different. This infection was not so easily transmissible from one human being to other. So it came rapidly from camel to human being, but its movement from man to man or human to human transmission was pretty less. The result was MERS tended to occur periodically, but MERS, numbers of people who actually had MERS continued to remain small, and they remain restricted in Gulf. Whenever it occurs, the traditional measures are again prescribed, the same safe distancing, the same cuff etiquettes, the hygiene related issues, they are expected to be followed.
In the first few months of 2020, COVID-19 spread quickly across the globe, reaching 10 million confirmed cases towards the end of June.
As China managed to contain it very quickly, despite the fact that perhaps it may have had started little earlier in China than is reported, but the containment measures were strong and they could manage to contain that. But by then it had already got transmitted into different countries, and today what you see is a pandemic.
On 11th March 2020, WHO had declared COVID-19 as a pandemic. Europe and North America saw the first major outbreaks in April 2020, but as they began to ease, Latin America and Asia started seeing an increase in cases. The virus infects lung cells, leading to respiratory failure.
This virus is slightly different. It also comes from coronaviruses. All these viruses don't have an effective vaccine as of now, whether it is SARS, whether it is MERS-CoV. Both the diseases don't have right kind of effective treatment is not available for all the coronavirus infections as of now. However, this particular COVID-19 has certain unusual features that it is highly transmissible from human being to another human being. The result is today you are counting the numbers of those who are infected in millions.
After being seen as an infection spread by respiratory droplets for months, WHO acknowledged emerging evidence of the airborne spread of novel coronavirus after a group of scientists urged it to update its guidance on how the disease spread between people.
We acknowledge that there is emerging evidence in this field, as in all other fields, regarding the COVID-19 virus and pandemic. And therefore, we believe that we have to be open to this evidence and understand its implications regarding the modes of transmission and also regarding the precautions that need to be taken. Our group, together with the experts who are part of it, really highlighted the importance of research in the field of different transmission routes and in particular through droplets of different sizes and understanding really what is the relative importance of this and also understanding the dose of the virus that is needed, in particular in this route of transmission that is the aerosol or airborne transmission.
After one of WHO's top scientists said that transmission of novel coronavirus by people who never developed symptoms was very rare, drawing widespread skepticism, the scientists came out with a clarification on asymptomatic carriers of the virus and onward transmission by them.
There are some estimates that suggest that anywhere between 6% of the population and 41% of the population may be infected but not have symptoms, with a point estimate of around 16%. I don't want to get too technical, but that we do know that some people who are asymptomatic or some people who don't have symptoms can transmit the virus on. And so what I was referring to yesterday in the press conference were a very few studies, some 2 or 3 studies that have been published that actually try to follow asymptomatic cases, so people who are infected over time, and then look at all of their contacts and see how many additional people were infected. And that's a very small subset of studies. And in that, I use the phrase very rare. And I think that that's misunderstanding to state that asymptomatic transmission globally is very rare. What I was referring to was a subset of studies.
There are claims and counterclaims on the origins of the virus that causes COVID-19. The narrative and counter-narrative have pitted global powers against each other. In May, the World Health Assembly, the WHO's top decision-making body, passed a resolution calling the agency to work with other international groups to identify the source of the virus and the route of introduction to the human population.
Knowing the source of the virus is very, very important. It's science, it's public health. We can fight the virus better when we know everything about the virus, including how it started.
The way coronavirus was studied was in the first SARS epidemic. Scientists went to the sites of origin of the epidemic in China, and they went to bat caves and markets and so on. And what they studied was they isolated this virus and they looked at how its gene sequence is, and they found something which is very interesting. What they found was bats incubate these kinds of viruses, and they are sort of an active laboratory for these viruses. And the reason for that is bats have an extraordinary high metabolism when they are flying. And as they're flying, they allow these viruses to replicate, but their own immune system contains the spread of the virus in a very effective manner, so they don't get affected. So that is the source. They mix and match and do things in a random way, and they invent keys without knowing what the lock is. And the lock is in our body, and the key is in the bat. And somehow, because they make millions of different kinds of keys, they make one random key which fits in the receptor, which is the lock in our cells. Now, normally we would never meet a bat unless we come in close proximity by living in bat caves, going to bat caves, or using wet markets. If we do that long enough, either from bats or other animals in such situations, and this one we think went from a bat to a pangolin to a human because of the gene sequence, the lock and key fit happens, and then the virus enters us and uses us as a host. So this is an incredible example of the way evolution by natural selection works. The key doesn't know of the existence of the lock, but it plays around with the lock and key in bats and in other animals, but it doesn't know that it fits beautifully with a human lock. But that chance event is made something certain by us coming close to bats or other such animals constantly.
After reports emerged of a second wave of COVID-19 infections, the WHO clarified that the world is witnessing the second peak of the pandemic because the virus hasn't been suppressed enough to quell transmission to end the first wave.
Most of the world right now is still very much in the throes of the first wave of this pandemic. Some countries in Europe, in Southeast Asia, North America have been through the peak of a wave of infection and are slowly, carefully making their way out of that situation. The disease has not reached a very low level, maintained a low level, and then come back sometime later in the year. This is possibly in some countries related to reopening of society, remixing of people, and being in a situation without adequate social distancing, without adequate measures in place, and without adequate capacity to test and isolate suspect cases and quarantine contacts.
Virologists in India have zeroed in on many variants of the virus.
Literature does not point to any particular mutation that is associated with increased virulence, but there is one particular mutation which is known as the D614G, which leads to reduced S1 protein shedding. You know, it has spike proteins S1 and S2. So it leads to reduced S1 protein shedding, which could be correlated with enhanced infectivity of the virus.
Most people infected with the COVID-19 virus experienced mild to moderate respiratory illness and recovered without requiring special treatment. Older people and those with underlying medical problems like cardiovascular disease, diabetes, chronic respiratory disease and cancer develop serious illness.
It tends to have a higher chance of a patient dying if it affects the older age group population or people who have chronic morbidity. And interestingly, the way to stop this infection or prevent this infection continues to rely on the same age-old methods which we talk of. It is unfortunate that what we learnt in 2002, how to prevent SARS, was not practiced throughout. What we learnt again when it came to MERS, that we have to follow the similar precautions, we didn't continue to follow. We did it only for a short period of time. And today we are trying to talk to people that they need to adopt the same measures which we had talked about from 2002 for those illnesses. Briefly we changed, but today is the time. We need to ensure that what we have learned today will continue to be practiced over a period of time. We don't forget it. We will ensure that it is practiced.
As global novel coronavirus cases continued to rise, WHO sounded an alarm, saying that there would be no return to the old normal in the foreseeable future, with too many countries headed in the wrong direction.
If the basics aren't followed, there is only one way this pandemic is going to go. It's going to get worse and worse and worse.
We don't need to wait for a new virus to come and teach us the same precautions which, if we would have followed, newer viruses would not have come.
If we don't learn lesson from the present pandemic, then I think it will be a real disaster more than the pandemic.
The world is learning from pandemics, from adopting sanitation practices to not spitting in open places. But we must learn to adapt faster to be prepared for the next pandemic. We also need to look inwards to see if our mobility patterns have made us more vulnerable to microbes that evolve 40 million times faster than humans do. The pandemic has left many unanswered questions. Did novel coronavirus begin to spread long before its first cases were reported? Why was there a low infection and death rate from COVID-19 in Japan, South Korea, Taiwan, Hong Kong and Vietnam? What do Twitter trends from across the world indicate about the time of origin of COVID-19? Why are certain countries reporting the bulk of COVID-19 cases? Was there a mystery virus swirling in different parts of the world long before the world took note of COVID-19? Was there any prediction about an unknown pathogen with pandemic potential before novel coronavirus was officially reported? And will the world get to know the truth about the origin of novel coronavirus? BioQuest will return with answers.